afternoon. I'm Dr. Panos Kougias, cardiologist from Brigham and Women's Hospital in Boston. I'm here at the 2025 AHA Scientific Sessions, and it's a pleasure for me to join Dr. Panos Kougias, who is from the VA Health System, New York Harbor, as well as from SUNY Downstate. And we're here to talk about Dr. Kougias' randomized trial of liberal versus restrictive transfusions in high cardiac risk patients following vascular and high risk non-cardiac surgery. Welcome, Panos.
Thank you. It's great to be here.
Tell us a little bit about the background of the trial.
Well, it all started actually quite a few years ago. It was back in 2014 or so. The issue of transfusion goes many years back, and whether to transfuse, as you know, is a very common question in clinical practice. And way back in the day, we didn't have so much information. The trial started from our desire to really generate high quality data in a clinical area where data didn't really exist. In 2014, we had only one trial in high cardiac risk patients, the FOCUS trial.
Now, are there data for patients undergoing cardiac surgery or patients following myocardial infarction?
At the time, there were a couple of trials after cardiac surgery, but as you know, it's different because after cardiac surgery, the cardiac lesion is in theory fixed already. So we were interested in understanding what happens when the patient has high cardiac risk, doesn't have the coronary artery lesions addressed, and goes through a high risk non-cardiac surgery.
Well, terrific. Well, tell me, who did you recruit? How many patients and across how many sites?
So we were able to recruit across 16 sites, 16 VA medical centers, and we recruited 1,428 patients. Major surgeries, high cardiac risk. All the patients had ischemic heart disease or peripheral vascular disease or stroke. So ischemic heart disease or its equivalent.
So these are predominantly male veterans, I would assume.
Male veterans, 98% were male patients.
Right. Okay. And what's the difference in your trial with respect to the liberal versus restrictive strategy for blood transfusion?
So we randomized in the liberal group if the patient dropped their hemoglobin below 10 grams.
Below 10?
Below 10.
Mm-hmm.
And the restrictive was below 7 grams per deciliter. So it was quite a bit of a gap between the two.
So on average, how many transfusions did the liberal group receive?
They received about 2 units per patient.
Per patient. And in the restrictive group?
So I was interesting because not everybody received transfusion in the restrictive, as you might expect. So 23 or 24% of the patients only received transfusion.
Is that right? So a quarter of the patients.
A quarter only, and it's an interesting dynamic to see playing in there.
Right. And what were your endpoints, and when did you measure the endpoints?
The primary was a composite of death or major ischemic events. And by major ischemic events, we counted MI, we counted renal failure, coronary artery revascularization, and stroke, all the way out to 90 days. So we wanted to go past the typical 30-day outcome range, and we extended out to 90 days.
Did any of the patients die during this period of time?
They did, about 5%,
5%.
Which is what we typically see. And we have seen over the years this proportion to be actually reduced over time, but 5% of the patients died.
Was there a difference in the composite outcome between the two groups?
Very small, very small. The liberal arm, in the liberal arm, the composite outcome occurred in 9.1%. On the restrictive arm, 10.1%. So a very small difference. Turned out it wasn't significant statistically, only a 10% relative risk reduction.
10% relative risk reduction and did not achieve significance. So
it did not.
Were you able to say then that the liberal strategy was not better than a restrictive strategy?
This exactly, it wasn't better, and that's why we believe that it's safe to use a restrictive strategy even in this high cardiac risk population.
Did you look at any key secondary outcomes?
We did, quite a few, and we did have a surprising outcome. We had a composite of cardiac complications except for MI. So we put in this composite heart failure, arrhythmia, and non-fatal cardiac.
So the secondary outcome, did it prove different between the two groups?
Actually, it did. It was a bit of a surprise. On the liberal arm, we had much better outcomes. We had the event rate for the liberal group was 5.9%, versus 9.9 in the restrictive. So this was quite a bit of a difference.
And this composite did not include myocardial infarction.
It did not at the beginning, but when we saw the significant difference, we did a post hoc analysis. We added myocardial infarction, and this treatment effect persisted, although the significance from a statistical point of view, it went away because the upper bound crossed 1. It was 1.01. So technically you can say it wasn't significant statistically, but the treatment effect, it did remain substantial, even after the MI was added.
Even after that. What kind of arrhythmias did you observe?
It was an equal mix of atrial fibrillation and left and right bundle branch block.
So you included bundle branch block. And was this new onset bundle branch block?
Some of it was new, some of it was pre-existing that needed to be treated interventionally after the study started.
Well, if I'm not mistaken, the individual components of the key secondary outcome did not differ, but the composite was different.
Yeah, correct. There was a very strong indication because the point estimate in both of those key components favored the liberal group.
The point
individually, you're right. The point estimate did, but individually, the outcome was significant.
So with the overall neutral results of the trial, this would be a hypothesis-generating observation.
This is correct, although I wouldn't dismiss its clinical relevance completely just because the difference was significant and the event curves kept diverging over time. If you look at the event curves of this secondary outcome more than 90 days, they kept diverging with consistency. But again, non-adjudicated, secondary outcome, you have to be cautious in the way you...
I think that's wise of you to caution us about the strength of the observation. But has this affected the policy at the VA in terms of blood transfusions following surgery?
We anticipate that it will. I think the VA will be more restrictive. We do understand that the safe thing to do going forward for this high cardiac risk patient will be to be restrictive in the strategy. And we, as the results have been publicized, we do anticipate that this will have impact on the way veterans are treated.
Well, it certainly seems over the last several years that the evidence base is building, that it could be too much of a good thing if you liberalize transfusions following surgery or even in the context of myocardial infarction. Is that fair?
Well, I think there is a research imperative into that. I think we need to understand that the restrictive arm is the way to go. There may be a subgroup of patients that will benefit from the liberal strategy. More work needs to be done. Some subgroup of patients may benefit, others will not. There is quite a bit more to learn as we're moving forward. We do need more precise way to assess maybe heart failure or arrhythmia to understand if this is truly something we need to be paying more attention to.
Very good.
Maybe not.
Well, thank you very much, Panos. We will stay tuned, and thank you for sharing your insights and the results of your terrific trial.
Thank you so much.
You bet.